All right. Well, thank you very much for the organizer for a tremendous meeting. For a meeting just starting, this is, I can predict this is going to be almost another TCT here. So having said that, I'm going to take a completely controversial, different opinion from John here. And instead of using a subintimal approach for doing things, I'm going to tell you my approach. My approach is quite simple. I almost always go for the intraluminal space. And for many reasons. Subintimal angioplasty and long total occlusions, I know we've seen some data that maybe the patency is good, but I can tell you in the diabetics and the limb ischemia patients, the patency is not good. It's about 45% to 62% at 1 year. The subintimal crossing will limit the use of your debulking device. I'm a no-stent strategy guy, and I can tell you that I would go for a debulking device, and without an intraluminal approach, this is going to be very difficult. Clinically significant distal embolization can still occur in about 0 to 3% of the subintimal angioplasty, depending on the study that you read. Effectiveness of DCB, we've seen a little bit of data there, from the previous speaker, but I can tell you we don't have really good data, in terms of being in the subintimal space. We need really concrete data to say, yes, DCB in subintimal space works well. And stenting rate is very high, 90% with a subintimal approach. So we take the intraluminal space very seriously, and that's what we do normally in our lab. If you look at the XLPAD data, 452 CTO, if you try to cross, at least in that particular experience, 72.6% were intraluminal, 27.4% were subintimal, and if you are in the subintimal space, you have 92% stent rate. If you are in the intraluminal space, you have about 62% stent rate. Again, something we try to shy away from is to use stenting as a primary strategy. So let me take you over some of the devices. The reentry devices, assumingly you end up in the subintimal space, we have currently 4 of them: the Pioneer from Philips, Intier from Medtronic, Offroad from Boston Scientific, and the Outback LTD from Cordis. So let's take you over the Pioneer catheter. It uses an intravascular ultrasound catheter. It has a monorail 0.14-inch delivery lumen. You deliver the Pioneer catheter into the dissection plane to the desired true lumen reentry. You use the curved retractable nitinol needle to advance it into the true lumen. The way you do this is simply you have the catheter in the subintimal space, and you can see the true lumen with the good flow using the color on the ultrasound. You position them at 12 o'clock, both lumen and needle, and you advance your needle, and it goes straight into that true lumen. It works very nice. The pros and cons, the IVUS allows for real-time imaging, when the needle is deployed, and the IVUS confirms the patency of the vessel, where the needle enters. Calcium can be a limit to IVUS, and the catheter usually does not track very well in our experience. I don't know about the newer one that was released, but that was from the previous Pioneer catheter that we had. Expense and ultrasound availability may be a limitation. When we look at the Outback catheter, this is a 5 French multi-purpose-like guiding catheter with a hypotube ending in a curved nitinol needle. The needle is retracted. The device is delivered over an 0.14-inch wire to the point of the true lumen reentry. The catheter is manipulated under fluoroscopic guidance. The LTD acronym is very helpful. You locate, the lumen. You put your L directed toward the lumen. And then you fine-tune your catheter after you rotate your II by 90 degrees, where you see a T right over the lumen of the vessel. And then essentially you go back to your original position and you deploy with the L positioning directing toward the true lumen itself. So if you look at the, let's see. If you look at an example here, this is a CTO. This is a subintimal approach. The 035 wire was exchanged using a catheter to an 014 wire. This is your Outback. Again, using fluoroscopic guidance, you position your needle toward the true lumen. That's the L directed toward the true lumen. You have your wire in, and then you finish your procedure the normal way. The pros and cons, of course, you don't need an IVUS in this case. You're using mostly fluoroscopic imaging. The catheter tends to easily track over the wire, and needle deployment is less controlled, but the L and the T markers are very helpful to have on this catheter and actually works most of the time. So another system, and that we use this also in our lab, the Intier. It's a reentry system. It's a catheter plus a wire system. As you can see, the tip of the catheter is a balloon shaped almost a flat shape. When you inflate it, it positions itself nicely toward the lumen. You have 180-degree opposed and offset exit ports. These exit ports, allows to get your wire into the true lumen under X-ray guidance. This is an example. When you deploy the balloon, you can see the two parallel line of the balloon. Then you position your II in a way where you can see only one line, and then you choose the port, either the proximal or the distal port, to go toward the true lumen, depending on your position compared to the true lumen. This is an example from our lab where you have a CTO. This is the balloon inflated initially. You can see the two lines. Then you change your II till you get a straight line. And then this here, the proximal port, seems to go toward the lumen, which is medial to the balloon itself. And then once you're in the lumen, you can finish your case the way you want it. This is the offroad. We start using that in our lab recently. It works really very nice. It's an 035 guide wire compatible catheter. The tip of it is a balloon that is conical shaped. Once you inflate that, it positions itself very nicely toward the lumen. There's a stylet that you can use. You put through this catheter, and it has a lancet tip right at the tip of it. And once you advance that, it advances straight into the lumen, and then you can have your 014 wire right through. Of course, you take your catheter, again, finish your procedure the way you like it. So these are all very nice systems. They all work very well. With the off-road system, we always advise a 50 to 50 dilution contrast, for that balloon tip. Try to avoid severe calcium. If your reentry failed, reposition the balloon after deflating it, either a little bit more proximal or distal. And then again, you can push the catheter just a little bit gently, and that helps positioning the balloon straight toward the lumen. This is an example also from our lab where a CTO is crossed. This is the balloon inflated. The stylet is advanced right through the balloon. It goes straight into the lumen, and the wire is placed right through that stylet. Again, let's talk a little bit about the intraluminal crossing, which essentially is our first line of treatment. We use several devices, the Forerunner and the TruePath, Viance crosser, and the Wildcat Ocelot, are all systems that can be available. And let's go over those very briefly. The Forerunner catheter does not have a guide wire lumen. Essentially has bilateral hinged pieces, and it dissects right through the plaque. It's braided hydrophilic shaft with a shapeable distal end. It's a device that has been used initially in our lab. Currently we don't use it as much, but it certainly is a viable device. The Viance is multi-coiled wire shaft, results in a 1-to-1 torque. It has a fast spin torque handle that when you spin it fast, the physician essentially has to spin that device, and the faster you spin it, it goes, the torque is transmitted right to the tip, and very gently it penetrates into the intraluminal space. The advantage of this, no capital equipment, it's easy to have in the lab. The Wildcat system uses a spinning tip which corks through the tough plaque. The smaller version is the Kitty Cat. It has a spiral flute, and the shaft is about 150 centimeter. Once the OCT is loaded on that catheter, that becomes the Ocelot catheter. Of course, the biggest issue with the Ocelot is you have to have a light box, and you have to have a learning curve to learn this catheter, but it works very well, and you will see from the data the crossing using OCT guidance seems to be pretty high. If you look at the TruePath, this is from Boston Scientific. This uses a diamond-coated distal tip. It rotates at 13,000 RPM. Essentially transform the energy into a rotational energy. Has a shaping tool. You can shape it up to almost 10 to 15 degrees. And it's 018 compatible catheter that you have to use. The tool itself has a control unit right here, has a motor housing, and the drill device is right at the tip of this catheter. The crosser also uses energy to turn into vibrational energy, goes at 20,000 cycles per second. The tip penetrates very well. Interestingly, it has an atherectomy code on it, and many labs actually use it for that purpose. So let's look a little bit about the data of the Viance versus the Forerunner. That's from the XLPAD. You can see the technical success was 73%, very similar between the two devices. The Viance was used more below the knee and toward popliteal disease. But again, they look to be similar. The failure rate is about 25% with these devices. However, when you start looking at the energy-driven devices, like the crosser and the TruePath, their crossing success is now up to 80 to 83%. And if you look at imaging-based crossing, with the Ocelot, your crossing success seems to be about 97%. Again, there is other devices that are available. You can use the laser. You have the Wingman, which is a relatively new device that uses a hypotube microcatheter with a bevel tip. You also have your center cross from Roxwood. This has an anchoring mechanism that allows better support for your crossing catheter as it goes into the intraluminal space. The bottom line is you have a lot of devices, and I believe you have to have 1 or 2 devices in your lab for both intraluminal and subintimal to master pretty much these devices rather than try to master all of them at the same time. Thank you very much.